Clinical chemistry, gonadal hormones. Starting with the testes, by the 6th week of development, primordial germ cells have migrated to gonadal ridges. Bipotential, so 46XX or 46XY. Ovarian pathway is followed unless TDF, the testis-determined factor, is present, and the TDF gene is on the Y chromosome. Paired ovoid regions that serve dual functions, the production of sperm and the production of reproductive steroid hormones. Functional anatomy, the testes are located outside the body, encased by a muscular sac. Blood flow and contraction of the dartos muscle is regulates the temperature of the testicles to 2 degrees Celsius below core body temperature, and that's vital to sperm production. Spermatic cord can retract testicles into the inguinal canal when injury is threatened. It's composed of 2 anatomic units, the seminiferous tubules, which contain germ and Sertoli cells for sperm production, and interstitium. Spermatogenesis, the spermatogonia, are stem cells that form sperm. Spermatogonia undergo mitosis and then meiosis, and haploid cells transform to form mature sperm. Mature sperm has a head, body, and tail so that it can swim. Hormonogenesis, testosterone is controlled by FSH, or follicle-stimulating hormone, and LH, or luteinizing hormone, which are produced by gonadotrophs. Hormonal control of testicular function, impaired pulse generation of GnRH, or gonadotropin-releasing hormone, leads to inadequate production of LH and FSH, which results in hypogonadism. Testosterone enters the cell and converts to THT in cells rich in 5-alpha reductase, such as some hair follicles and prostate. Physiologic actions of testosterone. So in prenatal development, early in development, embryos have primordial components of the genital tracts of both sexes. The primitive gonads become distinguishable at about the 7th week of embryonic stage. Postnatal development, testicular function is reactivated during puberty after a period of quiescence to produce testosterone that results in the development of secondary sex hair, like on the face, chest, axilla, and pubis, enhanced linear skeletal growth, development of internal and external genitalia, increased upper body musculature, and development of the larynx and vocal cords with deepening of the voice. Effect on spermatogenesis, paracrine effects acting with follicle-stimulating hormone on the seminiferous and Sertoli cells, inducing spermatogenesis. Effect on secondary sex effects, promotes the growth of various target tissues. Disorders of sexual development and testicular hypofunction. So hypergonadotropic hypogonadism is characterized by low testosterone. Klinefelter syndrome is the presence of an extra chromosome. So in Klinefelter's, it's XXY. Testicular feminization syndrome is the most severe form of androgen resistance syndrome. 5-alpha reductase deficiency is a rare cause of androgen insensitivity and results in a mutation encoding the type 2 isoenzyme. Myotonic dystrophy presents with primary hypogonadism, frontal balding, diabetes, and muscle weakness, atrophy, and dystonia. Testicular injury and infection, mumps, orchitis, Sertoli cell only syndrome, present with small testes, high FSH levels, azoospermia, and normal testosterone levels. Disorders of sexual development and testicular hypofunction. Hypogonadotropic hypogonadism, occurrence of low testosterone levels together with low or inappropriately normal FSH or LH levels. Kallmann syndrome, hyperprolactinemia, type 2 diabetes, age, and pituitary disease are all described here below. Please take some time to read through these and make note of them. Diagnosis. Both clinical and biochemical features must be met. The timing of the sample must be considered, so the circadian rhythm. Multiple estimation of free and bound levels is done on different days. FSH and or LH levels are elevated in primary etiologies, but inappropriately normal in or low with secondary etiologies. Pituitary MRI should be done in secondary cases in young people. Older people often have secondary or tertiary dysfunction. Clinical signs and symptoms should be corroborated with low testosterone levels. This is a really good chart to review on the clinical diagnostic evaluation of male hypogonadism. So you can kind of follow this flow chart through and see what different levels mean and what disease would ultimately be indicated. Testosterone replacement therapy. So parenteral testosterone is an intramuscular injection. Transdermal testosterone is absorption from a patch through the skin. Testosterone gel, the gel is applied to non-genital skin, but there is a risk of transmission to others. Buccal testosterone, a plastic tablet, is placed along the gum line. And testosterone pellet is a subdermal implant. Monitoring testosterone replacement therapy. Prostate-specific antigen, PSA, must be evaluated because with testosterone replacement therapy, we may see an increase in certain types of prostate cancers. Blood counts, lipid levels should be checked every 3 to 6 months after initiation and yearly thereafter. Routine clinical evaluation for leg edema, sleep apnea, and prostate enlargement. Pharmacologic use of testosterone may reduce sperm count. If PSA is elevated, prostate evaluation with possible biopsy is recommended. Active prostate cancer is a contraindication to testosterone replacement. The ovary. So if there's no Y chromosome or TDF, an ovary is formed. Paired organs with dual functions, the gamete or ovum production and steroid hormone production. Primordial reproductive cells in the female produce solitary gamete. Hormones from the hypothalamus, pituitary, and ovaries prepare the uterus for implantation of an embryo. In the absence of implantation, the uterine lining is shed, and that's what menses is. So they're oval-shaped organs. They're positioned near the fimbrial end of the fallopian tubes. Adult ovary measures 2 to 5 centimeters in length and weighs about 14 grams. Contains 2 to 4 million primordial follicles that are present at birth. The follicular phase, all but one, is recruited follicle in a cycle atrophy. The Graafian follicle, the remaining follicle, contains maturing ovum. The luteal phase, the Graafian follicle releases an ovum in response to luteinizing hormone. So luteinizing hormone stimulates ovulation. And then luteinization, the Graafian follicle develops into the corpus luteum. The corpus luteum's goal is to produce a hormone to prevent the shedding of the lining. So progesterone is going to be produced by the corpus luteum so that the uterine lining is not shed while we're waiting to have the implantation event. If there is no implantation event, eventually the corpus luteum will stop producing that progesterone and menses will occur. Hormones produced by the ovaries. So estrogen promotes breast, uterine, and vaginal development. Progesterone induces secretory activity of endometrial glands. Androgens in excess leads to hirsutism, loss of female characteristics, and the development of male secondary sex features. Others, inhibins A and B, inhibit FSH production. Activin enhances FSH secretion and induces steroidogenesis. Folliculostatin, relaxin, follicle regulating protein, oocyte maturation factor, and meiosis-inducing substance are also hormones. The menstrual cycle starts on the first day of menses. It consists of 2 phases of parallel events occurring at ovaries and the endometrium. So the follicular phase begins with the onset of menses and ends on the day of the LH surge. So LH surge happens right before ovulation. A rise in FSH stimulates estrogen production. And then there's the luteal phase that starts with the extrusion of the ovum about 36 hours after the LH surge. And then it ends with the onset of menses. Hormonal control of ovulation. So central control of FSH and LH secretion resides in gonadotropin-releasing hormone, pulse generator of arcuate nuclei and medial preoptic nuclei of the hypothalamus. Positive and negative feedback responses exist among estrogen, progesterone, LH, and FSH production. A mid-cycle surge in LH production stimulates a series of events that culminates in ovulation, with FSH levels falling thereafter. Pubertal development in the female, development of breast tissue, pubic hair, menses, measured by the Tanner staging system. Menstrual cycle abnormalities. Amenorrhea is the absence of menses. Oligomenorrhea is infrequent or irregular menstrual bleeding. Hypogonadotropic hypogonadism is a deficiency of FSH and LH that can cause secondary amenorrhea. Hypergonadotropic hypogonadism is ovarian failure with the elevation of FSH concentration. Polycystic ovary syndrome can cause infertility, hirsutism, chronic anovulation, glucose intolerance, hyperlipidemia, dyslipidemia, and hypertension. This chart is another good chart that you should take some time to review. So this is a diagnostic approach to secondary amenorrhea. Read through this, make note of all of the different abbreviations in here and what those hormones are, and try to follow the flow chart to learn more about the diagnostic approach. Hirsutism is abnormal and abundant androgen-sensitive terminal hair growth. Cause is most commonly idiopathic, or PCOS. Should only be considered in the context of women's ethnic origin. So it's measured using the Ferriman-Gallwey scale. 9 areas include the lip, chin, sideburn region, neck, chest, abdomen, upper back, lower back, and thigh. Allots points on a scale of 1 to 4 based on hair thickness and pigmentation. A score of greater than 8 is consistent with diagnosis of hirsutism. Estrogen replacement therapy. It remains a conscientious issue. Women's Health Initiative study found that following 16,608 postmenopausal women who underwent estrogen therapy had an increased incidence of invasive breast cancer and venous clot formation. There was no benefit in cognitive decline or coronary artery disease, and there was a reduction in bone loss, colon polyp formation, and menstrual symptoms, hot flashes, or vaginal dryness. It remains a treatment option in selected women after risk counseling.